Hello and welcome to another lecture for human sexuality. Today we're going to talk about birth, contraception, and lactation. So as part of talking about birth, we are going to talk about pregnancy. And to talk about pregnancy, we have to first start with conception. So let's first, before even looking at conception, look at some fertility factors. First, nutrition affects puberty, meaning when we talk about fertility, if we remember, we're talking about when people can get pregnant or the ability to get pregnant. So when we talk about that, we have to talk about puberty. So one of the things we talked about when we talked about puberty before is how nutrition affects puberty. So how some girls who are getting a good diet, lots of caloric intake, they hit puberty earlier than others. So in the past, though, most girls didn't reach puberty until about the age of 14 and didn't start regular menstruation until around the age of 18 to 20. This is something we talked about before, and this is why most marriage laws involve that age of 18, because that's when most girls became fertile historically. Now it's becoming younger and younger, and again, that fertility now, many girls are reaching regular menstruation at 14, 15, 16, right in that range. So it's really a different environment than it was historically. And that's what it's saying now. In our present environment, there's enough nutrition that many girls are reaching puberty earlier at around 12, and some even earlier, and are starting regular menstruation by 15. So it's really that environmental shift. Now let's look at conception. So conception is when the union of the mature ovum and sperm, the ovum from the female, the sperm from the male, the union of those after sexual intercourse or whatever other means is used to inseminate the egg, that conception is when these two come together. The genetic materials in both unite together to form what we call a zygote. So at this point, we don't call it an embryo, we don't call it a fetus. At this point, we just call the union of those two a zygote. And it really is just the genetic makeup of those two at this point. Looking at that a little bit more in detail, only about 1 in every 1,000 sperm actually reach the egg due to various different things like vaginal acidity that we talked about before, and how things like the Cowper's gland reduce that, but it doesn't eliminate it. Gravity's a factor, swimming against the current's a factor, wrong tubes, so you've got two directions they could go. There's also sperm that have defects in them, so only about 1 in 1,000 reach the egg at all. And many of them reach it after conception occurs, but only 1 in every 1,000 will even reach it. So looking at that, only about 2,000 even go in the right tube. And then once they get there, the sperm secretes an enzyme which thins the outer layer of the egg, allowing them to penetrate. And then once the one sperm enters the egg, the outer layer thickens, stopping other sperm from entering. So once one is in, it is done at that point. In the rare cases where more than one sperm gets in, usually conception does not occur in those cases. As far as pregnancy, let's transition into that. One thing to talk about here is a lot of people consider a missed period as the first sign of pregnancy, but that is not always the first sign. In some people have a pseudo period after they're already pregnant. Some people have irregular periods anyway, so along those lines it might not be that first sign. We can, through blood tests as early as the 8th day after conception, detect pregnancy, but with urine tests it's about the 3rd week. So think about that when you're looking at over-the-counter pregnancy tests, which use urine. that if it's not within the first few, if it's not beyond the first few weeks, so if it's not 3 weeks or beyond, and even the 3rd week, it's a bit iffy. You're looking at about the 4th week before it really can be conclusive for a urine test. But if you're doing it in that first 2 weeks, it's as likely to give a false positive or false negative than anything. And that's why if anytime a urine test indicates that pregnancy might be present, that's when you should see the doctor and get a blood test, because those are much more definitive. Another way to detect it is after about a month after a missed period, so about 6 weeks after conception. Pelvic exams can show a softening of the uterus, so this is one way to also detect it if there isn't blood tests present, or the ability to get blood tests, or if you don't even maybe think you're pregnant. Well, a pelvic exam can indicate that pregnancy is possible. Let's go through the environments that the developing offspring goes through. So we're going to start with the prenatal environment. As we said, we got the zygote there, but now we've got the prenatal environment, which is the mother's womb. The mother's womb is a protective environment for fetal development, and it is where the developing offspring can grow and its organs can develop while being in a protected environment and getting the nutrition it needs from the mother. However, there are some vulnerabilities that are still present, and we will go through those in just a minute. Let's look at the stages in the prenatal environment. So we've got 3 stages. We've got the germinal stage, which is about the first 2 weeks. I'll talk about this a little bit more in a minute. You've got the embryonic stage, which is the first 2 months after that first 2 weeks. And then the fetal stage, which is from the end of the embryonic stage until birth. You notice these terms, we often use the term embryo or fetus when describing a developing individual, developing offspring. This is really where these terms come from. Before the embryonic stage, we still just look at it, that first 2 weeks, it's still just a developing zygote. Then the embryonic stage, from about 2 weeks to 2 months, we consider it an embryo. And then from about 2 months on, it's considered a fetus. So this is where we get those terms from. Starting in that first stage, the germinal stage. So this is right after conception. So within 36 hours after conception, the cell is already dividing. It divides repeatedly on its way to the uterus. So about 3 to 4 days goes by from conception till the zygote gets to the uterus. During this time, it is rapidly dividing. Another 3 to 4 days from the time it gets to the uterus, it's basically wandering around looking for a good place to implant. And then after about 7 days, so this is where you get that 3 to 4 day and 3 to 4 day. After about 7 days, the zygote implants on the uterine wall. Prior to this implantation into the uterine wall, there's a plethora of things that can affect whether it will implant on the uterine wall, and we'll get to later how many times a conception does occur, but it never even gets to the point of implanting on the uterine wall. So a lot of the times where conception may occur, there is no viable pregnancy from it because it never implants on the uterine wall. Along those lines, and we'll talk about some of the birth controls later, but one of them I don't talk about is uterine ablation, where basically the uterine wall is scarred with hot fluid, and when that occurs, or when that happens, basically after that, any conceptions that do occur any implanted eggs cannot implant themselves into the uterine wall because of the uterine wall being now just scar tissue. During this time, the cells begin to group off, and they'll eventually become different structures. And as I said, during this time, the cells are dividing, but really you can't tell anything at this point. Even the picture you see in the top right is not really what you would see at this point. It would almost be just a blob of cells at this point. Next, you get the embryonic stage. So the embryonic stage, we count it as an embryo now. After implantation has occurred and it's fully implanted until about the 8th week, and we'll talk in a minute about why the 8th week is important. But during this time, major organ systems are developing, rapid cell division is occurring, and one thing that occurs is development occurs from the head downward and from the center outward. So the head develops before the rest of the body, but they do develop rapidly thereafter. The internal, the organs, the spinal cord, that develops first, and then it goes outward from there. By about the 3rd week, the head and blood vessels begin to form. So from this point, blood could start to flow. It doesn't flow yet, but the blood vessels are beginning to form. The 4th week, you get a primitive heartbeat that starts to pump. Really, it's not a full heartbeat, but there is a muscle reflex action that is starting to push blood flow through the blood vessels that are forming. During this time, the arm and leg buds start to appear. So even that picture you've got in the top right here, this is more towards the end of the embryonic stage. This isn't the beginning, because the legs and arms are already there, whereas 4th week, it would just be buds that would be there. Then finally you get the fetal stage. This is from about the 9th week on till birth. And really what differentiates the embryonic from the fetal stage is where the major organ systems, the fingers, the toes, the genitalia, things like that are formed. And yeah, it's about 3 months before fingers and toes and genitalia, but it's really what differentiates the embryonic from fetal is organ development. So most organs are at least mostly developed by the end of the embryonic stage, most internal organs, and they continue to develop on beyond that, but most of what we count as critical periods, which we'll talk about in just a little bit, happen in that between the 4th and the 8th week, in that range. By about the mid of the 4th month, the fetal movements begin. So this is where kicking and moving can be felt. At the 7th month, the fetus turns upside down. If this doesn't occur, there can be problems with the birth. One of the big things that's happening during the end of the embryonic stage into the fetal stage is the cells that have been rapidly dividing are now starting to proliferate, migrate, and differentiate. What that means is cells of the body are going to their different respective areas and becoming the structures that they will be in the end. At about 23 weeks, we get what's called the age of viability. That's when survival outside the womb is possible, because the brain and respiratory system have developed to a point where even if a respirator is applied, that the fetus can survive. Prior to this, even with external systems like respirators, things like that, if the lungs haven't developed enough that oxygen is work from outside the body would be even useful, then at that point in time, it's not, even with all the medical technology we have, it wouldn't be viable to have the fetus outside the womb. So 23 weeks, mainly due to because the brain is developed enough that it can make the respiratory system work, and the respiratory system is developed enough that it can utilize oxygen. As far as another thing that's going on during the fetal stage is learning. So the fetus begins to recognize repeated familiar sounds. It can recognize the mother's voice, or if there's repeated sounds around the mother while it's in the womb, it can recognize these and actually be soothed by these if there's distress. Let's shift real quick to talking about teratogens. So teratogens are drugs, medications, diseases, or environmental factors that affect fetal development negatively. So I said the mother's womb is a protective environment. It protects against most things. However, there are some things it does not protect against, and teratogens are one of the things it does not protect against. Important for teratogens is the critical period. So that is when these different things like the drugs, the environmental factors, radiation, pollution, all of these things, when they affect fetal development the most is during different critical periods. So each organ system has its own critical period. And these critical periods are when that organ system is growing the most rapidly, when it's developing the most rapidly. So any teratogens will affect the fetal development the most when it occurs during a specific organ system's critical period. And some teratogens affect multiple different organ systems, and whenever the fetus is exposed to them, if any of those systems are during their critical period, that's when you tend to find defects in those systems. So we're not going to, in this class, get too much into the different teratogens. If you're interested in more, I suggest taking developmental, and that class goes into all the different teratogens and looks at them specifically. But there is one teratogen that is a interesting one, and that's the thalidomide. I'm saying it wrong, but it was a drug prescribed in the 1960s for morning sickness. However, it causes great fetal or infant deformities. So it causes systems to be deformed or in other ways impacted. And one of the reasons we know these critical periods is because infants that were born, they could see where the different developmental abnormalities, that's what I was looking for, abnormalities, organ abnormalities, things like that. They can look and see what abnormalities are present and correlate that with when the mother took this drug. So if it was the infant had issues with their stomach, then they could find that when the mother took that drug is when that would be when the stomach was developing. Or if there were issues with the palate, the roof of the mouth, the cleft lip, things like that, they could then determine that when that drug was taken is a critical period for that organ system. Another thing that's important is dosage and duration. So dosage and duration is greater doses and for longer durations, longer exposure and greater exposure, it means more likely to have serious damage. This is one of those things why it's argued that having a glass of wine while you're pregnant or a small glass of wine, is not necessarily bad. So doctors are gonna say it's bad, but I'm gonna look more at the science. I'm not encouraging people to drink while they're pregnant or smoke while they're pregnant, of course not. I'm just saying for drinking, one thing we know is if it's low dosages, and it doesn't happen that often, so the duration is low, then abnormalities are unlikely. I'm not going to say they're completely not going to happen, but they're unlikely. Smoking, on the other hand, that's one where it's hard to have it in such a low dosage or duration for it to not have a negative impact. However, medical associations now are saying that if you smoke when you get pregnant, that quitting smoking actually might cause more harm because of the stress than just reducing smoking. So they're actually suggesting reducing smoking and eventually quitting, but not necessarily quitting cold turkey. So dosage and duration is important, and critical periods are important. And finally, genetic makeup is important. This is an individual's susceptibility to harm based on their genetics. So this is where genetic predispositions come in. Infants who have a genetic predisposition to certain things, certain disorders, teratogens may have more impact on them. Those who have resilience, teratogens may have less impact. And the environment, but that is, the environment is basically where the teratogens come from. But one thing that does affect teratogenetic effects is postnatal environment. So some of these defects that occur can be overcome by a positive postnatal environment, postnatal being after birth. This slide shows those critical periods, and I just want to point out here, let me use red, that you see here from the earliest one started about the 3rd week, but if you look through here, most of them don't start until the 4th week. So this is where a lot of people say, well, I didn't find out I was pregnant until I was 3-4 weeks pregnant, and I was drinking a lot or doing drugs before that, things like that, and they're worried about development. But you see here that for the most part, prior to the 4th week, maybe some central nervous system or heart issues, but I wouldn't be that stressed out about things that occurred before you found out you were pregnant. It's more of, look at that, about 4th week on, 4th week especially until about the 8th week, that's the period of time where a lot of the different abnormalities can occur. Yes, there's some before, there's some after, but that the light blue you see here, the teal, is when major abnormalities can occur, and that is mainly from the 4th to the 8th week. Okay, let's transition into some other things that occur during pregnancy and talking about those and looking at why some of them occur and related to that. As I said, if you're interested more in teratogens that we were just talking about, developmental psychology looks at those in much more detail. I'm more interested in teaching in this class the pregnancy as a whole, looking more at the mother rather than fetal development. So let's look now at things like morning sickness. About half of women experience morning sickness. And this morning sickness can occur throughout the day. So when morning sickness, it's in quotes because morning sickness really doesn't mean mornings. It can occur at any point in the day. Relating to that, and I'll come back to why it's related to that, but relating to morning sickness is miscarriages. Miscarriages, also called spontaneous abortions. I prefer the term when we're talking in here about spontaneous abortions or using the term spontaneous abortion because spontaneous abortion is essentially when the mother's body is deciding that that developing fetus or that developing embryo is not viable. It can have many causes, and about 3/4 of the ones that occur within the first 16 weeks. Why is that the case? That within the first 4 months, it's because the mother's body has ways of detecting if there is abnormalities in the developing fetus. So if the mother detects that there is abnormalities, things that are likely to cause the fetus to not be able to survive to term or to have issues of surviving after, the mother's body is likely to have a spontaneous abortion, meaning the mother's body is likely to get rid of that developing fetus so that the mother can get pregnant again and hopefully the next time with a viable offspring. The rates are much higher than most people would ever expect. It's estimated that about 50% of all fertilizations, so about 50% of the time when a sperm fertilizes an egg, it ends in a spontaneous abortion. And this is because of those things I was just talking about. It is quite often the case where things like mutations, so we didn't really talk about mutations in here, but when the sperm is produced or the egg is produced, there are different things that can occur when those different sex cells are produced. And one of the things that can happen is mutations. Some mutations can be advantageous, but and some are just, there's no effect, but most mutations are actually harmful. So if the mutation was harmful, the sperm fertilizes the egg, the mother detects that there is a harmful mutation there, she is likely to have a spontaneous abortion. So about 50% of all pregnancies end in spontaneous abortions. And this is, again, what we classify as a miscarriage, but we almost look at miscarriages more as things that happen later in the pregnancy, because spontaneous abortions, most women, the vast majority of women, do not even know they're pregnant when it's occurring, because the 3/4 happen in the first 16 weeks, the first 4 months, but even more than that happen in the first 2 to 3 weeks. So I was talking about how when it implants on the wall, or if it even implants in the wall, that's when a lot of these spontaneous abortions occur. Looking at, though, on the positive side, normal gestation period is about 280 days. This is time from insemination until birth. A good, easy way to do this is find the first day of the last menstrual period before the pregnancy and add 9 months from there. So it's about 8.5 months of pregnancy, but we look at it as 9 months because you can go back to the last menstrual period and go 9 months from there. I said I'd come back to morning sickness, because morning sickness is one of those interesting things, or those things that we can look at as having an effect on fetal development. First off, before I even get into morning sickness, or before I get into talking about why morning sickness is there, think about for a second how something like morning sickness would evolve. So we're talking about evolution here. And when we look at this, we look at, well, morning sickness is when a woman who is pregnant typically vomits. When she, in this case, you can look at it from an evolutionary perspective, she is expelling caloric intake. So calories that she's taking in, she is expelling out. From an evolutionary perspective, the mother should want to keep in as many calories as possible, because that's aiding in fetal development. So for morning sickness to still occur now, there has to be an evolutionary reason, because if there wasn't an evolutionary reason, evolution would have selected it out long ago. One thing we find is that morning sickness actually occurs more in environments where there's more teratogens. So what morning sickness is actually doing in these cases is helping the mother expel teratogens, not necessarily just caloric intake. Because it's more present in environments where there's more teratogens, it means that the morning sickness is actually having a benefit there. Food-related nausea as well is more common in foods that contain more teratogens, like red meat. Many women that are pregnant get nausea around things like red meat. It's because red meat has a higher chance of having bacteria and other contaminants in it. So because of that, there's more nausea and morning sickness that comes when there's more possibility of taking in these types of things that might harm the fetus. And I said I'd come back to the relationship between morning sickness and spontaneous abortions. What's been found is that women who have less morning sickness, women who have fewer instances of morning sickness, actually have more spontaneous abortions than those who have more morning sickness. And this includes women who take medications to block morning sickness. So women who take a medication to block morning sickness, they are more likely to have a miscarriage than women who are not taking those medications. Morning sickness is beneficial. There is a reason that a pregnant woman is having morning sickness. Stopping that actually does more harm to fetal development than most people realize. So Again, I'm kind of up on a soapbox here, but morning sickness, yes, it sucks. Vomiting sucks, but it's actually, if you're pregnant and you're having morning sickness, if your partner's pregnant and having morning sickness, that morning sickness is for a reason. Let's now transition into a little bit of other things, like when do women have their first child? This has changed a lot. I've only got numbers from 1970 and 2005, but you can see that in 1970, 64% of women had their first child between the ages of 20 and 24. This isn't including teenage mothers. That's an entire another chart, not something to look at right here. Just consider that of those who didn't have a teenage pregnancy, 64% in 1970 had their first child between 20 and 24. That's dropped down to 37% now. And even if that 25 to 29 has gone up a little bit, but basically stayed the same, what's really changed is that those from 30 to 34 and 35 to 39, those in their 30s, are having their first child in those ages at least 4 times the rate than they were before. So this is one of those things. Why is this the case? Well, this is the case mainly because of things like education. More women are going to school before they start getting pregnant. This is delaying when people get married. We already talked about that. People are getting married later. They want to get a job. They want to have college education. That means that the first pregnancies are getting pushed back in many women. Let's look at another topic from an evolutionary perspective, and that is the gender of the offspring. First off, it's very clear, this shouldn't be news to anyone, but the gender of the offspring is determined by the sperm. We already talked about this earlier in the semester. The sperm is either an X or a Y, and that determines the gender of the offspring. However, if you combine that with some of what we've been talking about things like spontaneous abortions, you can actually look at the fact that it's not the gender of the offspring a woman has is not just determined by the sperm. What I mean by that is that if there are gender imbalances in the population, what's been found is that women will have more offspring of the underpopulated gender. What do I mean by that? What I mean is let's say there was a war and 50% of the men were wiped out. So now in the population, 75% are women and 25% are men. There is a gender imbalance in the population. That is, there are more women than men. From an evolutionary perspective, if we look at it even deeper, there is an advantage to having offspring of the underrepresented gender. What do I mean by that? Well, if there are less men than women, men will be able to more easily find a partner and have children because there will be more women to choose from than there are men. If there are more men than there are women, a woman having a female offspring would be more advantageous because that girl, when she grows up, will have more, be able to be choosier when choosing who to have children with. So there are evolutionary advantages to being part of an underrepresented gender. So if there is anything that happens, like I said, war, where it wipes out one gender disproportionately more than another, then women will start having that underrepresented gender at a higher rate. It's not a guaranteed thing, but it is at a higher rate. We see this anytime we look throughout history where things like wars kill off large percentages of men. After World War II in Russia, where a large percentage of the men were dead, women started having more male children. You see this in China now, and it's one of the unfortunate side effects of China's one-child policy that they had for so long that they've gone back on now. But they had this one-child policy, but everybody wanted a boy. So if women were pregnant with girls, they would have abortions, they would put it up for adoption, do various different things like that. Well, as a result, many more male children were around than female children. Well, the result of this is that women started having more female children because it was an underrepresented gender. So it kind of backfired in that way. How does this occur though? Because again, the gender is determined by the sperm. Well, this occurs mainly through spontaneous abortions. That is, if the woman gets pregnant with a fetus of the overpopulated gender, the chances of a spontaneous abortion is much higher. One thing to look at though is at conception, the gender ratio is about 120 males to every 100 females. But at age 20, it actually gets closer at birth, it's about 105 to 108 males to every 100 females, and at age 20 it's about 100 to 100. First of all, let's look at, well, why is conception occurring at higher rates for male sperm than female sperm? And that's partially due to things like a male sperm being better swimmers, stuff like that. So the conception gender ratio is obviously going to be higher for males. There's an evolutionary reason for that. We'll get into that actually when we look at why it's 100 at birth, or not at birth, at age 20. That does decline though to about 105 to 108 to every 100 at birth. Why is this occurring? Well, because it's more likely with a male offspring to have a spontaneous abortion due to male offspring being more likely to have genetic abnormalities. Why is that the case? Well, we can look at things like the chromosomal abnormalities. You can look at the fact that in females, they have 2 X's. Because of that, if there is a deficiency on the X chromosome, they've got another X chromosome to make up for it. Whereas in males, they have an X and a Y. If there is a deficiency on the X chromosome or the Y chromosome, there isn't another chromosome to make up for it. Therefore, they're at an increased risk of having chromosomal abnormalities. So we now have this 108 to 100 ratio. Why is it then that at age 20, it's 100 to 100? Let you think about that for a moment. Why do, even if there's more males at birth, at age 20, they're at about equal? The answer to that is mainly that boys are dumb. What it comes down to is that males are more likely to do things that would get them killed, like take risks or go out and be more adventurous, things like that. Things that can potentially get them killed. So more in childhood and adolescence, more males die than females. So even if the ratio is 105 to 100 at birth, by age 20, it's 100 to 100. Let's look at something else then, that is mother's age. So now we're going to look at some factors in the mother. If you are interested in what I'm talking about here, again, developmental psychology talks about this in more detail. I'm just kind of giving an overview of some of these things. You can get more detail in a developmental class, but we are talking about birth, we're talking about pregnancy, and we're mainly looking at mothers. So let's look at some things relating to mothers. First of all, very young mothers have higher than normal rates of birth complications, premature delivery, and or stillbirth. Well, why is this the case? Various different reasons. Very young mothers, their body isn't fully developed yet, so of course they're going to have increased risk of things like premature delivery. But even beyond that, very young mothers are less likely to seek out medical help. If they get pregnant, they like to keep it secret, things like that. So they might continue not getting the proper vitamins. They might continue doing things that's not healthy for the developing fetus. And because of that, they are at increased risk of all of these complications. However, on the other hand, women that are older, they're more likely to experience trouble getting pregnant rather than these complications with birth. They do have a higher rate of miscarriage, higher rate of that spontaneous abortion. That goes back to what I was talking about with abnormalities, genetic abnormalities. Well, as women get older, their chances of having eggs with more abnormalities or more harmful mutations increase. Same with as men grow older, but we'll talk about that in a minute. They're also at an increased risk of low birth weight infants for various different reasons, like the fact that their body is not at a point anymore where it can properly handle the pregnancy. As far as the mother's psychological state, it basically comes down to stress and anxiety. If prolonged and severe stress and anxiety are experienced during pregnancy, there can be many complications due to that. Things like faster and more irregular heart rate, fetal heart rate, stunted prenatal growth, premature birth complications, things like that. And this is why when I was talking earlier about smoking, how quitting cold turkey causes severe stress on the system, well, this actually translates into causing harm to the developing infant. So it's recommended to quit, just not cold turkey. Stress specifically, infants who are born to highly stressed mothers tend to be smaller, more active, more irritable, more prone to crying, delays in cognitive development, increased risk of schizophrenia, things like this. So this high amounts of stress to mothers. And this goes back to one of those things I was talking about with younger mothers. Younger mothers are more likely to experience stress while they're pregnant. So in single mothers fall into this category, mothers who are being abused, various different things that can cause these types of stress are things that can increase these harmful effects on the fetal development. Mother's nutritional intake is very important. So doctors recommend about 300 additional calories a day with a weight gain of 25 to 35 pounds for normal weight women. Malnutrition can have many effects, spontaneous abortions, stillbirth, neural tube defects. This is one of the ones where if it happens during that critical period when neural tubes are developing, stunted growth, cognitive deficits, these types of things. It's why, specifically to that neural tube defects, it's why you find most cereals are folate enriched now. So the federal government mandated it that cereals had to be folate enriched. This was about 80, 90 years ago that it was mandated because the folate actually decreases the chance of having neural tube defects. And one of the big things recommended is prenatal vitamins. And this is why I said some very young mothers who aren't getting prenatal vitamins. These prenatal vitamins really help with making up for anything that might be missing. Vitamins, there's mixed reviews on whether vitamins have effects or not, or how much of an effect they have on adults. And if they've got deficiencies, of course, vitamins help. And that's the big thing here. Prenatal vitamins aren't necessarily going to help even the majority of people. What they're there for is if for some reason the mother is having a deficiency in some vitamin or mineral, the prenatal vitamins make up for that and therefore through that avoid the different developmental abnormalities that can occur. We talked about mothers, let's transition into fathers. Specifically, we'll start with younger, so teenage fathers. Increased risk of birth complications there. This goes back to the exact same thing we were talking about with the younger mothers, and that is that if the father's younger, then it's less likely that the mother is getting in to get proper medical care, unlikely that the mother is getting proper nutrition, unlikely that the mother is getting those vitamins, things like that. On the other side of the spectrum, children born to much older fathers have an elevated risk of heart defects, neural tube defects, and kidney problems. This again is due to the fact that as men get older, they're more likely to have complications with their sperm. Likelihood of Down syndrome is actually greater when both the mother and the father are older. If just one is older, it's not necessarily an increased risk. It's when both are older is when you get that increased risk. And then finally in men, advanced maternal age, 50 and older, is a risk factor for schizophrenia, just like increased maternal age. Okay, we talked about the prenatal environment. We talked about some things relating to mothers and fathers. Let's now look at the perinatal environment. I'm going to be very generous. I'm not going to make you watch a video on birth. If you want more of that, go to developmental. Even though in developmental I don't make people watch a video of birth, I just make them look at the things that occur in the delivery room right after birth. But that being said, we do need to explore that. So the perinatal environment is the environment surrounding birth. Prenatal, again, the mother's womb. Perinatal, environment surrounding birth. We'll get to the postnatal in a minute, which is the environment after the birth. In our modern day, we have modern day birthing practices. So historically, and for quite a while there, prior to modern medical technology, it was much different than most people had their children at home. Then we had modern medical technology. And for quite a while after we had hospitals and doctors and things like that, they wanted to make the birth as sterile as possible. So what they did is they would exclude anybody other than the mother from the room. They would have the room just bare white walls and very clean, sterile environment. However, it turns out this causes extra stress to the mother. Extra stress to the mother causes extra complications in the delivery. So what is actually recommended now is a medical setting and use of technology, but in a home-like setting. So you find that delivery rooms now are much more open and warm and welcoming. You get things like control over who assists with the delivery, control over who is in the room when the delivery is occurring, like other, maybe even just friends, but definitely family members, the father, stuff like that. In a more warm, welcoming, supportive environment, a lot of that stress is decreased, not eliminated, but decreased, and therefore there are less complications with it. I'm not going to get into other types of non-medical births like home births and wet births and all that. If you're interested in more of that, I talk about it a little bit more in developmental, but for the purposes of in here, we're just looking at this medical birth. So what happens here? So a day or so before labor begins, you could have a discharge of bloody mucus. Some women start to think that that means they're having a miscarriage. No, this is normal. Doesn't happen in all women, but it is normal. Don't stress out about it. About 1 in 10 women will have their water break as the amniotic sac bursts. This is a big misnomer you see on TV where women have their water break almost always. No, only about 10% of women have this actually occur. Usually it has to be done as a part of the actual birth process after or as birth is occurring. Other signs of labor that can occur: indigestion, hard to tell because women that are pregnant have indigestion. Diarrhea, again, hard to tell because women that are pregnant have diarrhea. Abdominal cramps, backaches, again, things that normal pregnant women have, but they might have these at increased rates or different than they have been before that. And then labor begins with the onset of regular contractions. So when we look at that, this is where you get false labors. Contractions can occur weeks before, sometimes even months before, but it's when regular contractions are occurring that labor is beginning. There's 3 stages to birth. The first stage is where the cervix thins and widens. This is where most of the pain actually is occurring, besides the fact of in the actual birth happening. This can last from a couple hours to over a day. So this is so contractions might be going on, but not regular contractions, or even regular contractions are starting, just not that close together. During this time, contractions are becoming more frequent and strong. And at the end of this stage, the baby's head begins to move into the vagina. So again, this can happen from a couple hours to over a day, but at the end of this stage, it's when the baby's head begins to move into the vagina. Then you have the second stage. The second stage is when the cervix is fully dilated and the baby actually begins to move into the vagina, not just the baby's head, but the baby itself. This is when the woman is typically taken to the delivery room. So that first stage can last up to a day, sometimes even longer. During that stage, the actual birth isn't imminent, so the woman isn't even in the delivery room during that time. Then once the second stage starts, once you get full dilation of the cervix, the baby is beginning to move into the vagina, that's when the woman's taken to the delivery room. This can last anywhere from a few minutes to a few hours. In typical women, this is shorter, definitely shorter than the first stage, but it can still take a few hours, so it isn't something that is a quick process. Crowning is when the head is visible, and this stage 2 ends with the birth of the baby. So there's 3 stages. Stage 2 actually ends with the birth of the baby. So stage 1 is more of a preparatory stage. Stage 2 is the birth itself. And then stage 3 can last anywhere from a few minutes to over an hour. And this is when the placenta is expelled. So the placenta detaches from the uterine wall. And during this time, other things can occur, like physicians can sew up tears, episiotomies. Sometimes this just occurs naturally during childbirth. Sometimes the physician may even need to make an incision to aid in childbirth if the baby is too big. There's someone I know, when she had a baby, she was told by the doctor over and over again that the baby was fine, that it wasn't too big, but ended up having to make a over 4-inch incision to help the baby come out because the baby was so large, and she couldn't have sex for over 3 years after the birth because of healing from that incision. I'm not going to get into too much into C-sections. I'll talk about it in a minute, but I'm not going to get into more of the ethics of it. But there are some cases where C-section should occur, and with her, that is one of the cases where it should have occurred. Some complications that can occur with birth is anoxia. Anoxia is shortage of oxygen. So you see that in the top right corner up here. That's shortage of oxygen due to things like the umbilical cord being wrapped around the baby's neck, or other things like that, and this causes brain damage. Basically, what you see there, the holes you see there, are region of the brain where the brain died because there wasn't enough oxygen during and around the birth. Other things that can occur is assisted delivery. So here you've got forceps. Forceps typically don't harm the baby, or at least not long-term harm, but this can help pull the baby out if the baby's stuck. Same with the vacuum extraction that you see here. The main thing that happens with vacuum extraction is some people will have a bump on the top of their head for the rest of their life afterwards, but there's no other long-term medical issues that have been found to come from these types of assisted deliveries when they're helping the baby come out. The last one is C-section, which we'll talk about a little bit more. So looking at C-section. C-section is typically used when the baby's too large or the mother's too small, or if things like the fetus is out of position, the placenta prematurely separates, or if the fetal monitoring reveals that other birth complications are likely, like the umbilical cord being out of place. In 2007, 32% of U.S. births were by C-section. Again, I'm not going to get too much into the ethics of it, but one thing that is known is that many C-sections are unnecessary. There are situations where they're necessary, but it's the things like reduced liability and more revenue for the doctors. The doctors make more when there's a C-section, and there's reduced liability because there's less chance of complications. Many choose to have a second C-section after having a first one rather than having a vaginal birth. It actually used to be the case where doctors wouldn't even do vaginal births after a C-section. Now they will. This last one's an interesting one, and that's preference for scheduled birth. And that is one where this is just modern society where people want to have the birth on a certain day or at a certain time. Gotta get in, gotta get out, gotta get back to work, or maybe have a certain day in mind so the baby has a birthday, things like that. The issue here is, and again, I said I wouldn't get too much into the ethics of it. We'll just talk about the science of it. The issue here is that babies born by C-section tend to have slightly higher risks of other complications later in life, like breathing problems and things like that. Babies born from C-section are more likely to have asthma, various things like that. Okay, let's now look at the postnatal environment, and one of the subcategories of the postnatal environment is the neonatal environment. The neonatal environment is the first few months after birth. So during this time, ideas about parenting an infant are culturally constructed. So you get ideas like breastfeeding, ideas like co-sleeping, how you raise them for gender specificity, things like that. This is all culturally constructed ways of caring for infants. And what I really want to get at here is that what we consider appropriate, what we consider normal, other cultures might consider abnormal. And what other cultures consider normal, we may consider abnormal. So that's something to keep in mind when you're looking at infant care and how to do parenting, how to raise infants, things like that. There is a very big cultural construct that goes into it, and there isn't necessarily a right or a wrong way. One thing related to that, because like I said, I'm not going to get into too much of dealing with infants in this class, because we're more dealing with the sexuality side, so we're dealing with the more the parents, things like that. If you are interested in more, once again, developmental psych. But one thing I did want to talk about here, because we've talked about it before, is oxytocin. So oxytocin is released in large quantities before and after birth. Its original purpose is to induce births. Actually, its original purpose before that is for lactation. It starts lactation, so it's a mammalian chemical. It's only in mammals. Birds have a similar compound, but it's different in birds. In mammals, it's oxytocin, though, and it induces lactation, but it also induces birth. But one of the things here that it's been adopted for, or its evolution has kind of, it's piggybacked on, is this maternal offspring attachment. That is, that because of this oxytocin also has another name. Oxytocin's other name is the love hormone. It's a really bad heart, but there you have it. That's actually a really bad heart. It's besides the point. The point is oxytocin is called the love hormone. That's because it facilitates attachment. It's released in large quantities around birth, and mothers right after birth will tend to have an increased attachment to the newborn baby because of this release of oxytocin. This attachment that even in mothers who maybe had planned to put their kid up for adoption, or mothers who felt when they were pregnant that they weren't attached to the developing fetus and that they were worried they wouldn't be, many actually do become attached after birth because of oxytocin. Oxytocin is also released in infants, so infants become attached to their parents. And interestingly enough, it's also released in large quantities in males that are around pregnant women. And this actually aids in men forming attachments to their partner and to children, and it makes them more likely to stick around after the birth. And as I already said, it increases the bond between parents, which increases the likelihood that males will stick around. Another evolutionary topic, I love my evolutionary topics, especially when we're talking about stuff like this. There's a lot of evolutionary topics, but let's look at human birth as an evolutionary topic. That is, when we're looking at development in the womb versus outside the womb. And we kind of get a little bit of conflicting evolutionary needs here. We get the evolutionary needs of the developing fetus, that is, that its evolutionary needs are to grow as big and strong as it can, spend as much time in the womb as possible because it's a protective environment. The evolutionary needs of the mother are to have a viable offspring, but also to not remain pregnant so long because that can make it so the mother can't get pregnant again. As well as you have the morphology of the body. So really another looking at competing evolutionary needs here is the infant's head versus the birth canal. So again, the infant wants to spend as much time inside as possible, but wants to develop as much as possible as well. In humans, we have very large brains, so in human infants, it's most ideal to continue to develop the brain inside the womb. However, the size of the birth canal can only be so large. Women have evolved wider hips to have larger birth canals, but at the same time, that birth canal can only be so large. So we have these competing evolutionary pressures, and that's where we get the amount of time that women are pregnant when birth occurs is basically right at the cusp of when the baby's head is too large to come out, but is still, or when the baby's head is so large that it can still come out, but it still had the most amount of time to develop inside the womb as possible. And this is where you still get complications, like I said, of that friend of mine that had a baby that was too big and problems there. This is why a lot of more C-sections are occurring now. Women are actually, there's this societal pressure for women to be smaller and smaller. So women are becoming smaller, and those that are getting selected by men tend to be smaller. Because of that, you've got this conflict that's going on that's actually leading towards women actually having more C-sections in this way because their birth canals aren't large enough. Interesting stuff, right? Just a few other topics to talk about real quick. One is maternity leave. This is just one of the soapboxes I get up on. So the U.S. is the only industrialized nation in the entire world that does not mandate paid maternity leave. It actually only guarantees job protection for 12 weeks after birth, and that protection doesn't even apply to small businesses. Small businesses, you having a baby, you go out, you miss one day of work, they can fire you for it. It's completely legal for them to terminate your employment because you were out for having a baby. Other countries in the world that are more progressive, and again, this is just this progressive soapbox that I like to get up on, that these other countries in the world that are more progressive, you see 6 months, a year, sometimes even 2 years of maternity and paternity leave. Some countries alternate it, so the parents get 2 years between the two of them after the birth of the child. So for the first 2 years of the child's life, they can be around the mother or the father, or alternating between the two. So it's just really one of those things that yes, if infants that are around good daycare do not have a reduced attachment to their parents, but at the same time, it is better for children to be raised by their parents. Alright, off that soapbox. Next thing I'm going to talk about real quick is baby blues and postpartum depression. So baby blues it occurs in about 60% of new mothers. They have relatively mild, quickly resolved state of being tearful, moody, irritable, anxious, or depressed. Basically, this having an increased emotionality. So being tearful, being moody, irritable, light depression, light anxiety, things like this. So it's a relatively mild. So in most women, it's not that severe, and it's quickly resolved. So in most women, it is resolved within the first few weeks after birth. Why does this occur? Why does the baby blues even occur? Well, the baby blues occurs because while the mother is pregnant, there's this flood of chemicals in the body. During birth, there's a larger flood of chemicals in the body, and then after the birth, these chemicals just kind of wash out of the body. Well, you've got this elevated state that just kind of gets taken away, and this is why many women have this period of emotionality, irritability, moodiness, depression, anxiety that happens in the first few weeks after birth. Again, 60% of new mothers experience this. It's relatively mild in most mothers, and it's quickly resolved in most mothers. That is baby blues. So to differentiate baby blues from the thing we're going to talk about in just a minute, just remember relatively mild and quickly resolved. On the other hand, you get postpartum depression. That is, 1 in 10 new mothers experience this longer lasting clinical depression. So it's likely to be more severe, and it's likely to be, and it has to be longer lasting to be postpartum. What's been found though is that most women who have postpartum depression actually have a history of depression. So they're more at risk of getting depression in the first place. So they have history of it, and now they have it after. There's also additional life stressors that can affect it, lack of social support, lack of financial support, anything that's causing stress that makes the mother more worried or anxious about the raising of the child can increase the likelihood of getting postpartum depression. One thing we know though is that maternal postpartum depression does affect children's development. It isn't guaranteed, but in most cases it affects children's development. Those infants born from mothers with postpartum depression have a less secure attachment. We're not talking about attachment in here, but just note that the children become less securely attached. Children have more likelihood of being violent, and they have a predisposition to later depression themselves, mainly because when mothers are depressed with postpartum depression, they are not spending as much time and care and attention to the infant as a mother who doesn't have postpartum depression, which results in all of these things. Next topic I'm going to talk about real quick, we've got rapid fire topics here, is co-sleeping. That's the practice of sleeping in the same room or bed with the child. I bring this one up because it's a cultural thing. In some cultures, co-sleeping is common. In some cultures, it's not. Co-sleeping, again, can be same room, so they're in a crib or in a bed in the same room, but not the same bed, or even in the same bed. Challenges to co-sleeping are things like that it'll cause an increase in dependence. The child will be more dependent on the parents, or even that you could harm the child. Well, first of all, there's no evidence to indicate that there's an increased risk of harming the child for rolling over on them, unless there's other things occurring. Like if the mother is using substances or father is using substances, then in that case the mother may, if she's drunk or high, may roll over on the baby and suffocate the baby. But in typical circumstances, there is not really an increased risk of harming the child. There's also no evidence of increased dependence. So children that co-sleep with parents don't become more dependent on their parents. Actually, there's advantages to co-sleeping. You avoid elaborate sleep time rituals. Anybody who has kids knows that often as they grow older, in toddlers in that age, it's really difficult to get them to go to bed. You have to go through a big ritual. If there's co-sleeping occurring, those rituals tend to go away. There's other disadvantages to it, like you have to go to bed at the same time. We're not even getting into the context of privacy for sex and things like that. But there is arguments for and against co-sleeping. I only bring this up again because it's a very culturally dependent thing. There are some cultures where co-sleeping is the norm, and there are some cultures like the US where it's not really typical. Another topic, feeding, breast or bottle. So 70% of women now breastfeed for at least the first 3 months after birth. Mothers who are older, married, more educated are more likely to breastfeed. Breastfeeding does reduce risks of various different things, like infections, reduces allergies. There are antibodies being passed on through breast milk to the offspring. So breastfeeding or feeding of breast milk, so even if breastfeeding isn't possible, feeding of breast milk does have advantages. There are really no other significant differences. It's more up to you to decide what you want to do. Some women can't breastfeed, they don't produce enough milk. Some women prefer to not breastfeed. Some women have HIV and can't breastfeed because then they'll pass that on. But others who can breastfeed, it is cheaper. It has these reduced risks of infections, reduced risk of allergies, things like that. So the recommendation is to do breastfeeding, but it's, again, up to you to decide. Okay, let's now transition into the last topic of this lecture, and that is birth control. I'm just going to go over the overview of it. There's no demonstrations or anything like that. Just going to talk about it. Hopefully you've heard about these things before. If you are sexually active, hopefully you are engaging in some of these if you're not interested in getting pregnant. But the important thing here is that knowledge about what exists. This first one is, so we're going to look at some of the history of birth control, and this first one is specific to Canada, but the US is pretty similar, and that is in 1882 it was actually illegal to sell or advertise birth control in Canada. It's a really interesting thing that historically it was actually illegal to sell or advertise birth control. And again, the US wasn't specific to having it illegal, but it was very discouraged, and local places had it illegal as well. However, there was some transitions. In the 1930s, the economic depression led to a desire to have smaller families. So the Great Depression, people wanted to have smaller families. Birth control started to become available, but it was available at that point in time really to married women only, because it was viewed as if a woman who wasn't married was on birth control, then she was a floozy or a slut or whatever you want to call it. And because, again, at this point in time, the mentality was only married people should be having sex. In the 1950s, condoms became available in drugstores, but again, this was only as a way to prevent contagious diseases. It really wasn't marketed as birth control at this point in time. Then in the 1960s, we started to have our sexual revolution in the westernized world. This is where things like condoms became used regularly as a means of birth control, as well as where the contraceptive pill became available, which we will talk about. Let's look at some of these, like the oral contraceptives, the contraceptive pill. The pill, really what's going on with the pill is it consists of sex hormones. What I mean by that is estrogen, progesterone, those type of sex hormones. Those hormones that, if you remember when we were talking about the female cycle and ovulation and menstruation, that these are the hormones that control that. You have the combination pill. This contains man-made estrogen and progesterone. And these are designed for, again, to control the woman's cycle. There's also what's called the mini pill. This doesn't contain estrogen, just progesterone, and this has a slightly different way it affects the body. Oral contraceptives have about 99.5% effectiveness with perfect use, 97% with typical use. That's because many women do not take the pill every single day like they're supposed to, and therefore the effectiveness goes down. But in those that are taking the pill every single day, only 1 in about every 200 end up getting pregnant from it. So it has a very high effectiveness. So let's look at those in a little bit more detail. The combination pill first. This is one that's taken for 21 days. Then for 7 days you take no pill or a placebo. Typically you take a placebo so you keep on track. The placebo is just a sugar pill. It's just a different colored pill that just is taken again to keep track of days and keep it regular that you're taking these. The combination pill actually fools the body into thinking that it's pregnant. So in this case, no eggs mature, no eggs are released. The body is thinking it's pregnant. There's side effects to this, like weight gain, that come along with it because the body thinks it's pregnant. Then there's the mini pill. This one's taken every day for the month. With the mini pill, the mucus in the cervix thickens, therefore the sperm becomes less mobile. The lining of the uterus is less receptive to a fertilized egg. So with the mini pill, fertilization can occur, but it's less likely that if fertilization occurs, it's unlikely that it will implant into the uterine wall. There's also the morning after pill. So the morning after pill, just like the regular pill, has high doses of estrogen and progesterone. It actually has even higher doses than the normal birth control pill. It's most effective when taken within 72 hours. The morning after pill is typically designed to stop ovulation from occurring. So it's not designed, if pregnancy has already occurred, to really have much of an effect. It's to stop ovulation from occurring. Because ovulation is that one instant, we talked about this before when we talked about the woman's cycle, and for up to 3 days after ovulation, or 3 to 5 days after sex, sperm can survive, and it's there ready for ovulation to occur. The morning after pill then stops ovulation from occurring. The long-term health effects aren't known of this because of those high doses of estrogen and progesterone. Another device used is IUDs. IUDs are small objects that are inserted into the uterus by a doctor or a nurse. This has the benefit, they're left in between 1 and 7 years depending on the brand. And what happens here is it irritates the uterine lining and becomes toxic to the sperm and the egg. So sperm that are in the region end up dying or becoming non-functioning, and eggs, even if they're implanted or even if they're inseminated, don't implant on the uterine wall because of it. Next one we'll talk about is diaphragm. So this is a rubber cap or dome that's fitted into the vagina. It's coated with spermicide, and it's designed to prevent sperm from getting to the egg. Spermicides themselves, well, what's a spermicide? It's a chemical that kills sperm. Some people think spermicide is enough, but what ends up happening is those that just use spermicide, you get about a 21% failure rate in the first year. So about 1 in 5 couples that are just using spermicide with nothing else end up still having a pregnancy occur. So spermicide is a good supplemental thing, but not as good by itself. And that's just because spermicide can only get to so much of the sperm. Most of the sperm will get beyond it simply because of it being there. Then we get to condoms. Condoms made of animal membranes originally, can still be made of sheepskin, but they're typically made of latex, and now you have non-latex condoms that are not animal skin that have the same effectiveness of latex for those individuals who maybe are allergic to latex. They are a barrier. They can help prevent certain STDs, not all though. It is the only contraceptive device we currently have used and worn by men. There are female condoms as well. One thing we know is that only latex is effective against AIDS, or the new versions that are latex-free that are essentially the same thing. They just have other drawbacks, like they're not as durable, they're more easy to break. But one thing that's important here is not all STDs are protected against. And this goes back to what we talked about earlier when we talked about STDs themselves, and how some STDs are not necessarily transmitted just by blood. Some are transmitted by contact. You get things like HPV or herpes that can occur in regions that the condom doesn't block all contact. If they occur on the outer sides of the vagina or at the shaft of the penis, things like that, where contact will still occur even in the presence of a condom. So not all STDs are protected against with condoms. That's one thing to be aware of. It's also one of the reasons why when we talked about those STDs, how prevalent they are, because even in those who use condoms, they can be passed on. Condoms themselves, when used properly, have between a 97 and a 99% effective rate. And when you look at it, it just depends on proper usage, and it's just making sure they don't break, things like that. Again, I didn't want to get too much into the contraceptive methods. There's other ones that I didn't even talk about here. There's an interesting one being developed in India that hasn't come to the US yet, that is where a substance gets injected into I think I talked about it earlier in the semester, gets injected into the vas deferens of guys, which kills sperm that's going through it. So far it's got 100% effectiveness, and it can last about 10 years and can be reversed with another injection. Things like that would be so much better than things like oral contraceptive pills, because these oral contraceptive pills have a lot of side effects. I talked about weight gain, but there's other side effects like increased risk of cancer, depression. Anytime you're messing with hormones in the body, you've got a lot of major side effects that can occur, and it's why some of these devices, some of these contraceptives, are only recommended as temporary use. And then I didn't even get into things like having hysterectomies. I talked very briefly earlier about uterine ablation, but there's many different types of contraceptives and ways to prevent pregnancies that are out there. I really recommend looking into them and educating yourself. I just wanted to keep it brief for this class. Alright, that's the end of these slides. These slides ended up a little bit longer than I intended. Hopefully you get through these. I'll send out Blackboard announcements talking about the final and the last couple sets of slides. I still have to talk about paraphilias and then ethics. I am shortening the slides up because it took me so long to get these up, so expect those up in the next couple days. Thank you. Come back.